So yeah, good morning. It's a pleasure to be here. So there's going to be simultaneous translation, I think, is that right? Or not? Will I just you need translation? Yeah. There you are. So will I do I'll do a sentence or two and then stop. Is that generally how best it works? Or just keep going? Just keep going. Right, okay, thank you very much. So, yeah, as I said, it's a pleasure to be here. This is Edinburgh, where I am from. On the one day a year it shines, and it's not usually that nice, I'm afraid. I'm going to talk about the neuroimaging of psychotic disorders from a very clinical perspective. So hopefully that will be of some interest to you. I should check, are you all psychiatrists? Who's not a psychiatrist? Nobody's going to admit. Everyone is a psychiatrist. Okay, so it should hopefully be a fairly clinically oriented talk. Let's see if I can move on to the next slide. How would I move on to the next slide? I'm not sure this thing's working. I need to... So yeah, this is Edinburgh. It's sunny more than one day. This is the castle that overlooks the main street. Great. I don't need to do too much more for the Scottish Tourist Board. Thank you very much. Right, let's see if this works this time. Great. So this is the book that was kindly mentioned in my introduction, The Beginner's Guide to Sanity. It's no Turkish translation as yet. Hopefully someone here might want to do that. The whole point of the book is that it is written in pretty simple, straightforward language so that the average person with schizophrenia or their carers might be able to understand it. And it covers a whole range of stuff about diagnosis and treatment, all the way from antipsychotic drugs to knitting. And so, and as you can see, it's been quite well received in Amazon Prime, as reliable as that is. 14 ratings, 4.5 stars. And more reliably, perhaps, a user in the Lancet Psychiatry said it was very informative. So, anyway, on with the talk. This came out earlier this year. I don't know if you're aware of it. Maybe if you're a brain imager, you might be. But this paper came out in Nature, the world's premier scientific magazine, and caused quite a lot of stir amongst the brain imaging community, because it basically said if you want to find a reliable finding with brain imaging, especially if you want to correlate brain imaging findings with behavior, like symptoms or feelings or whatever it might be, you need thousands of people in the scanner. And most scanning studies include tens or hundreds of people. And I'm going to show you that this is partly true, and that it all depends upon the effect size of what you are measuring. And it's going to be one of the themes of my talk. Even Nature itself misrepresented this paper in the news section. So it's an example again of how media coverage of brain-mind issues can exaggerate and muddy the interpretation of things. But the bottom line remains true, that if you're studying brain-behavior relationships specifically, you probably do need thousands of people in the scanner. I'm going to skip that one. So I'm going to talk about brain structure in schizophrenia from a historical perspective, starting with CT and mainly structural MRI, with respect to cognition, psychotic symptoms and outcome. I'm going to talk a bit about what might be going on in the brain, particularly in schizophrenia, as people get it and after, and the potential of that for early detection and early diagnosis, and hopefully improving the outcome of the illness, and then something about PET findings. So there's a lot of neuroimaging techniques and I'm going to focus, as I've said, on these and these. And there's a lot of psychotic disorders, and I'm going to focus on this, mainly because these are the studies that have been done most. And there's very few imaging studies of these conditions in their own right when you have depression with psychotic symptoms or bipolar with psychotic symptoms. I think most of what I'll say is true about schizophrenia and to a lesser extent in the other conditions. So from an imaging perspective, as I'll show you, these other conditions are like milder versions of schizophrenia. There's a whole session on DTI tomorrow, so I'm not going to dwell on that, but I will mention it. I want to point out right from the start that I don't know if you know about this technique called pneumoencephalography, but the very first brain imaging studies of schizophrenia were done about 100 years ago now, where people would inject air into people's lumbar spine, into their subarachnoid space, and then turn them upside down, and the air would travel up to travel down to the head, and then they would take an X-ray of the head, and this was a way of imaging through air contrast with X-rays the size of the ventricles. It's one of the very first brain imaging techniques. Pretty dangerous, had a recognizable mortality, but it did show actually large ventricles in people with schizophrenia about 100 years ago, way before there was any antipsychotic medication. But the first modern imaging approach was with computerized technology, computerized tomography. So this is the famous study done by my boss, Eve Johnston, when she was working with Tim Crowe at Northwick Park in London. And they published this paper in The Lancet in 1976 in like 25 people with schizophrenia and 9 healthy controls. And this was arguably the first modern imaging study because it used computerized tomography to measure the size of the lateral ventricles in people with schizophrenia. And they found famously that the lateral ventricles on photographs, on an average of 4 measurements, were larger in people with schizophrenia than in healthy controls. And it's the first modern imaging study, but it actually involved taking a photograph at the widest point of the ventricles in the brain, and then Eve would put some tracing paper on the photographs, trace out the ventricles with her hand, and count the squares in the graph paper to get a measure of the area. It was that primitive. And she did it 4 times to get an average. Anyway, this enlarged ventricles width, or enlarged ventricle to brain ratio here, is one of the most consistent findings in schizophrenia research. There was very many CT studies. And Sean Lewis reviewed this literature in the British Journal of Psychiatry in 1990 and found that the most consistent correlate of the increased ventricular to brain ratio was cognitive impairment in 11 out of 14 studies. And that reminds me of the DTI literature. So these large ventricles that you're seeing here, the main reason that they are large is because of the reduction in the size of the white matter around them. So the ventricles are an index partly of loss of white matter, partly of reduced brain size in general. But the DTI studies, which measure white matter integrity, which I'll be a whole session about tomorrow afternoon, have very consistently shown an association between reduced white matter function and integrity and cognitive impairment in schizophrenia. So this reduced white matter in the brain is a principal reason why people with schizophrenia have cognitive impairment. So computerized tomography involved the use of X-rays, radiation, and so had a recognizable risk to patients. So when structural MRI came along, it was really rapidly taken up. It doesn't involve X-rays, you get better overall results of most parts of the brain in terms of imaging. And so there's been very many studies of people with schizophrenia. So myself and Suhaib Abukmail, originally from Palestine, now working in England, reviewed this literature of around about 42 studies of several thousand people with schizophrenia from structural MRI images. You can see here outlined is the hippocampus and amygdala as part of the temporal lobes. And if you look across that literature as a whole using these traditional region of interest hand-traced approaches, you find that the brain in schizophrenia is about 3% smaller on average than healthy controls. And particularly this applies in the prefrontal and the temporal lobes, where they are 5% smaller on average than in healthy controls. The effect size of that is around about half a standard deviation, a D of 0.5. And Ian Wright did a review of the literature following up on that, showing also that the putamen and globus pallidus were enlarged, which is probably down to antipsychotic medication. Now, that was a very laborious way of arriving at data. So people have come up with a variety of automated or computational approaches to measuring brain structure in schizophrenia and other conditions, using voxel-based morphometry, for example. Excuse me. And Rachel Henoya and Tim Crow reviewed that literature in the American Journal of Psychiatry in 2005 and found consistent results, again, with reduced grey matter density this time in hippocampus, amygdala, other parts of the temporal and frontal lobes. So we have consistent findings across two different technologies. And these days, people now use FreeSurfer, which is a technique that came out of Harvard, and automatically parcels the brain into 64 discrete chunks of cortex and then some subcortical volumes. And again, the results from that literature, as I'll show you, are also consistent with these old gold standard hand-traced volume measurements. So people like Danny Weinberger, for example, have been quite critical of the structural MRI literature, saying that some of these findings are artifacts or confounded by various things. But the fact that you show the same results with 1, 2, 3 different technologies addresses part of that problems, part of that argument. And the fact that you can also find now in post-mortem systematic reviews of the literature that the brain is 2% lighter and the hippocampus is about half a standard deviation smaller in post-mortem brains gives these quite nice correlation between live brain imaging and post-mortem dead brains with completely different potential confounders. So this is, if you like, a measure of the validity of structural MRI in schizophrenia. So I mentioned FreeSurfer, and I think Paul Thompson, who has set up Enigma, is speaking at this precise moment. Enigma is enhancing imaging genetics through meta-analysis or mega-analysis. And it's basically a worldwide endeavor, a bit like the Psychiatric Genomics Consortium, or the PGC, to get everyone around the world with data on schizophrenia or bipolar disorder or depression to use FreeSurfer in a similar way so that we can pool data and generate very large samples. And this has been going on for about 10 years. This is an old slide, so there's a lot more centers involved. But there's still a relative lack of data from Africa and South America, and I guess Turkey as well. And what this shows in terms of effect sizes in thousands of people with schizophrenia versus healthy controls, thousands of people with bipolar disorder versus healthy controls, and thousands of people with depression versus healthy controls is enlarged ventricles, most in schizophrenia, secondly in bipolar disorder, and minimally in depression. Reduced volumes of the thalamus with this similar range across conditions, reduced volumes of the hippocampus, mainly in schizophrenia, and so on and so forth. That's the intracranial volume. And then, again, these enlarged volumes of the putamen and other bits of the basal ganglia. So These results are now have been updated to include a grand total of 4,474 people with schizophrenia and 5,098 healthy controls in the Enigma consortium in a paper published by Theo Van Erp in Biological Psychiatry. And these results basically, to my mind, convincingly show that there are cortical thickness reductions in people with schizophrenia that are there from a relatively early stage in the illness. The key questions now are, when do these findings arise and when can we detect them? But there are other things that people have done with the Enigma consortium and other brain imaging studies to relate structural MRI to the severity of psychotic symptoms. So it's one thing showing that brain imaging can find a difference between healthy controls and people with schizophrenia, but what you'd ideally want to see is that those are related to some way to some of the key features of the condition. And indeed they are. So, and in particular, psychotic symptoms. So on the old hand-traced region of interest, 18 out of 30 studies reported reduced superior temporal gyrus volumes. The superior temporal gyrus is this bit up here on the left and on the right. And that includes, on the left, your auditory perception cortex, Wernicke's area. And that is smaller in people with schizophrenia. And the smaller it is, the stronger the correlation with symptoms like positive symptoms, especially hallucinations. So that was shown in 18 out of 30 studies using this very old but gold standard approach. Using voxel-based morphometry, the first kind of computational technique, again, if you look across the 8 studies that had been done with 438 patients, Gemma Medinus found an association between grey matter volume in the left and the right superior temporal gyrus and auditory verbal hallucinations. And most compellingly, which is basically true, this is a fact because it includes thousands of patients, is that if you look with free surfer in the Enigma consortium, positive symptoms are negatively related to superior temporal gyrus thickness in 1,987 patients. The effect is relatively small, but it is definitely there. So if you like, we have a direct relationship between the size of a bit of a brain in people with schizophrenia and the severity of their positive psychotic symptoms. It is not a massive effect. It's by no means accounting for the whole of the experience of auditory hallucinations, but it is there. It is an effect. It is a fact. And again, through the Enigma consortium, they have looked at the relationship. I've talked about the positive symptoms. They have looked at the negative symptoms in schizophrenia and find a weak correlation with prefrontal cortex thinning. So your prefrontal cortex is the bit of cortex immediately above your eye orbit, the orbital prefrontal cortex. And if that's thinned in people with schizophrenia, that is related to the severity of negative symptoms. So again, we have a brain behavior link in thousands of people with schizophrenia. So what about functional MRI? There's been an awful lot of functional MRI studies, and I'm not going to dwell on them, partly because they tend to be small and they don't reliably estimate the effect size that they're trying to measure, and therefore can't generate power calculations and can't persuade people like me that the findings are definitely there. But there are some very good functional MRI studies. My personal favourite is this one done by Suki Shergill at the Institute of Psychiatry in London, published in Archives in 2000. And what they did very cleverly, I thought, was each of the functional MRI scans lasts about 3 seconds to get an image of the whole brain. They would take a 3-second scan. They would ask people, were you hallucinating during that scan? So these were people who were in hospital for having their acute schizophrenia relapses treated. And the patient would say, yes or no, I was hallucinating or not during that 3-second scan. And if you build up this picture, if you do this over about an hour, you end up with hundreds of scans within a particular patient comparing their brain when hallucinating with their brain when not hallucinating. So it's like a perfectly controlled study in many ways. And these are the areas of the brain they found were associated with hallucinations in this study. So insula, Similar regions again, parahippocampal gyrus, here's the superior temporal gyrus, and the right thalamus. And people have used a technique called ALE, or activation likelihood estimation, to look at all PET and fMRI studies of hallucinations, and again find things like hippocampus and parahippocampal gyrus involved. And this is a different meta-analysis approach, again finding similar regions. I mean, it's one of these things, it's kind of obvious in retrospect. Of course, the auditory cortex is involved in the experience of auditory verbal hallucinations, but it's only obvious once you know for sure with structural and functional brain imaging. So these are the kind of things that we find reliably in people with schizophrenia. Impaired white matter integrity, reduced grey matter, thickness and volume, some abnormalities on fMRI, particularly related to symptoms, particularly auditory verbal hallucinations. So the key question, as I've alluded to already, is how do these things develop? If we can measure them early enough, perhaps even before people get ill, we might potentially have an early diagnostic technique, or a diagnostic technique. So I'm going to talk a little bit about how these conditions develop. Can I just check, am I speaking too fast or too slow or about right? About right. I think that's what that means. Does that mean about right? Or slow down a bit? Slow down a bit. Is that what that means? Okay, I'll try and speak slower. Right. So a lot of the research I've done is in people at high familial or genetic research of schizophrenia because they come from multiply affected families. We know that schizophrenia is highly genetic with a heritability of around about 80%. And there have now been, as summarized quite a while ago by friends and colleagues in Utrecht in the Netherlands, 25 studies in more than 1,000 first-degree relatives of people with schizophrenia, and these included 679 patients with schizophrenia and 1,100 healthy controls. And what these studies found, 9 studies, for example, looked at the hippocampus in first-degree relatives of people with schizophrenia and found a clear or small to moderate-sized reduction in the hippocampus in those at high familial risk. So this shows, at least in part, that some of the imaging findings I've talked about are genetically mediated or related. The other influence that is clear on hippocampal volumes is obstetric complications. We know in general and in people with schizophrenia that certain obstetric complications, particularly those that reduce blood's oxygenation supply, are associated with reduced hippocampal volumes in people who suffer obstetric complications and in people with schizophrenia. Now, these hippocampus volumes, if you remember, the effect size is around about 0.5, 0.6 in established cases. So this suggests in itself, but doesn't prove, that there are both genetically mediated changes in hippocampus and further changes as people move from being at high risk to developing the illness. And there are some studies that indeed do show that. Grey matter is generally released in familial high-risk people, and the third ventricle is slightly enlarged as well. And in the Enigma consortium, they have pooled all the available data from 1,228 first-degree relatives of people with schizophrenia, 852 relatives of people with bipolar disorder, more than 2,000 controls, and more than 1,000 patients with schizophrenia, and 666, which is an unfortunate number, of people with bipolar disorder. And again, you get this similar gradation of patterns in terms of volumes of the intracranial volume, the total brain volume, and these various other areas, whole brain grey matter, whole brain white matter. You get this gradation of effects. You get the biggest reductions in people with schizophrenia, the second biggest reductions in the patients with bipolar disorder. Then you get similar reductions in people with first-degree relatives of schizophrenia, and the smallest differences in the relatives of people with bipolar disorder. So again, you see a gradation of illness and genetic effects. This is using the now gold standard FreeSurfer software as part of the Enigma consortium. And so Enigma has recently published a paper in JAMA Psychiatry, which we were part of as part of very many people across the world, in people at clinical high risk. So these are, I don't know if you have early intervention for psychosis services in Turkey. You probably do have some, I guess. So people at clinical high risk are those who tend to present to early intervention services with delusions and hallucinations that are not in themselves bad enough or frequent enough to qualify for a diagnosis of schizophrenia. So they are deemed to be at clinical high risk of psychosis. And if you image those people, and the studies included 1,792 of them and 1,377 healthy controls, they have reduced cortical thickness with an effect size of around about 0.13. Now again, like I mentioned in the last slide, this cortical thickness is less than the cortical thickness reductions you see in people with schizophrenia. So again, it implies or suggests that there are further changes that occur between being at clinical high risk and actually having or getting schizophrenia. And that means that you could potentially use structural brain imaging to measure those changes as part of an early diagnostic test. And indeed, those with the most reductions in cortical thickness are most likely to convert, but there are also changes over time. So in our Edinburgh high-risk study, this is another picture of another sunny day in Edinburgh, we imaged a grand total of 162 people at high familial risk of schizophrenia because they came from multiply affected families. And we didn't just do this once at the age of 21, we did it every 2 years over the next 10 years. And during this time, 21 of these 162 developed ICD-10 schizophrenia. So we were able, for the first time really, to plot what happens in the brain in terms of structure as some people develop schizophrenia. And this is so this is the left prefrontal lobe, this is the right prefrontal lobe, and this is the volume as expressed as 100% of the baseline volume. So green shows healthy controls, and you do see some health-related reductions in grey volume from about the age of 21 onwards. That's, you know, sad to say, once you're 21, it's downhill from there in terms of grey matter and neurons and connections. But you see in high-risk people who had symptoms but didn't get schizophrenia, in red, and high-risk people who had no symptoms, you see a slight exaggeration maybe of those effects. But in the 20 people at high risk who went on to get schizophrenia, you can see more profound changes over time. So they are roughly losing, what, 2% of left prefrontal lobe volume over 2 years, about 1% a year over up to 10 years. And the extent of those changes were related to the extent of increasing hallucinations, delusions of passivity, and other delusions in a grand total of 434 scans. So this, again, suggests some progressive changes in brain structure, or at least changes in brain structure, as people are developing schizophrenia. And Bayan Alabi, who was a medical student actually from Syria in Edinburgh, and myself and Ed Bullmore did this review of the changes over time, the progressive imaging literature in people with schizophrenia around about the same time. And what this showed, if you looked across all the studies, how many? 1, 2, 3, 6, 9, 14 studies looking at changes over time in people with schizophrenia. This is a whole brain measure. You can see these are the individual study results. These are the weights that these studies contribute in the meta-analysis according to the size of the study. And this is the overall effect. About half a standard deviation over time in terms of whole brain reductions in people with schizophrenia, and a similar size effect across the studies looking at lateral ventricles changes over time. about half a standard deviation increases in volume of the ventricles over time with people with schizophrenia. So there are progressive brain changes once one has schizophrenia that continue at least for a few years. And if you express these as annual percentages, you find around about 0.1% of brain volume reductions, and 0.6% for whole brain grey matter reductions. You also find quite a lot of white matter reductions over time. So what causes the changes over time in people with schizophrenia? Well, probably related in part to risk genes for schizophrenia, although we don't know that for sure. We do know that alcohol consumption progressively reduces grey matter in healthy controls and probably also in people with schizophrenia. We know that cannabis can have similar effects, and those are very commonly used by people with schizophrenia and indeed the general population, at least in the United Kingdom. I suspect, but do not know, that inactivity possibly contributes to grey matter loss. You know, according to the kind of use it or lose it principle of the brain in general, across development and into old age, if people with schizophrenia are not doing anything, perhaps because they're over-sedated, I suspect that the bits of the brain they're not using as a result may reduce in volume. What has also been shown, it's only in 5 studies but I'm aware of, but in all 5 studies that have looked at it, is that the more you're losing in terms of progressive grey matter reductions over time in people with schizophrenia, the worse the outcome of the illness. So the post-mortem literature, if we come back to that, in people with schizophrenia, is that there is not actually a loss of brain cells. It's not a dementia. There is no schizodementia, or at least it's not typical. What is underlying the decreased volume that we see on structural brain imaging is reduced neuropil, or the connecting structures around neurons, and smaller neurons that are less well connected with each other. So the problem with schizophrenia is a lack of connectivity between neurons nearby and with other neurons in other parts of the brain. There's generally not gliosis in the brain in people with schizophrenia. There's not an inflammatory reaction that underlies most people's schizophrenia. There's quite a lot of evidence for glutamate and dopamine disruption that we'll come back to. This was nicely summarized by Paul Harrison in a very scholarly article in Brain in 1999. More recent, Osimo and colleagues have systematically reviewed the literature from post-mortem studies and of synaptophysin messenger RNA, and find reductions of this marker of connectivity in the brain in the CA3 region of the hippocampus and the parahippocampal gyrus, and also parts of the prefrontal cortex. So there's a fairly consistent story from the post-mortem literature of people with schizophrenia of small brains, reduced grey matter volume, probably because of less well-connected grey matter, i.e. neuronal cells, and less active grey matter neuronal cells. So now that we have a whole range of recognized genetic markers for schizophrenia through GWAS studies, we can directly relate the genetics of schizophrenia to the brain imaging results that I've been talking about. So this is the famous Nature, the PGC, Psychiatric Genomics Working Group for Schizophrenia in the Nature 2014. This is the Manhattan plot, as it's called, because it looks a bit like the skyline of Manhattan across all 23 human chromosomes, including the sex chromosomes. And you see there's 108 GWAS significant loci across the human chromosomes that are associated with an increased risk of schizophrenia. This is in more than 100,000 cases and controls. And these genes implicated include a range of glutamatergic genes and good old dopamine D2 receptor as well comes up. Now, none of these are diagnostic. Even together, pooled as a polygenic risk score, if you've heard of that, these are not going to be able to diagnose schizophrenia. These are risk markers of genetic effects. But what you can do, and you can do it at an individual level, you can take blood from each and every one of you or your patients, and you can see whether they have the risk SNP at each of those loci. You can add those effects together into a polygenic risk score that you can calculate at an individual level. And these account overall for about 20% of the liability to get schizophrenia at a population level. But interestingly, from a scientific perspective, you can relate these to brain volumes. So we did this, Emma Nielsen, one of my PhD students, we're talking about 2,000 or almost 3,000 scans from the UK Biobank data here. So a big data set. And this is the polygenic risk score for schizophrenia in healthy people in the UK, healthy people who have volunteered for the UK Biobank study, who are on average between the ages of 40 and 60. And you can see that this is related to free surfer extracted global cortical thickness and free surfer extracted global cortical volume. The effect is small but highly significant. So at a population level, at the whole human population level, the polygenic risk score for schizophrenia is related to reduced grey matter volume and thickness. It's an effect that applies at the whole population level, perhaps even more at the individual level of someone with schizophrenia. And in the Edinburgh High Risk study of people at high familial risk, when we looked at the various impacts on their reduced grey matter, we found the expected effect of alcohol use on increased right and left lateral ventricle volumes. We found an effect of cannabis use, particularly on these regions of the brain. We found an effect of childhood maltreatment or abuse or trauma on the reduced amygdala hippocampal volume that we have found. And these findings are by no means unique. In fact, they're very common. There's a very well-established literature that childhood maltreatment is associated with reduced volumes of the amygdala and hippocampus, probably part of an exaggerated stress effect, and that alcohol and drug use, as I've already said a couple of times now, are related to reduced grey matter in frontal and temporal lobes. So these are not necessarily to do with schizophrenia. What about the antipsychotic drugs that we prescribe our patients? This has been quite controversial in recent years. Do antipsychotics shrink the brain? And there's a whole range of different studies that speak to this issue. This, to my mind, is the single best review article. So these are, again, structural MRI studies relating antipsychotic drug doses as prescribed to patients to grey matter volumes. So this graph here shows the key finding, which is, if you look at the cumulative exposure to antipsychotics in terms of dose, the higher the dose that patients are on as a group in these individual studies, so this is 1, 2, 3, 4, 5, 6, 7, 8 separate studies, looking at the effect of dose of antipsychotics to here, grey matter volume, you find a significant effect. It's a small one, beta value of only 0.01, but it is a significant one. You also find changes over time in grey matter volumes here in this graph, just associated with the duration of illness, as I've said already. And you don't, in these studies, find changes at a whole brain level with psychotic symptoms. So what they found generally was that the more exposed to antipsychotic drugs in terms of chlorpromazine equivalents, the greater the changes in grey matter volume, with a small effect. So I think it is possible that antipsychotics have this effect, but there are a number of considerations about this effect that you need to bear in mind. So I've already shown you that in general, across schizophrenia as a whole, there are changes over time in terms of loss of grey matter. That's probably partly related to the illness, the symptoms, alcohol and drugs, and maybe also antipsychotic medication. And then the other thing to bear in mind is that it's almost certainly, if there is an antipsychotic medication effect, it's going to be dose-related. And I think if you dose your patients up with high doses of antipsychotic drugs, that they're lying rigid in bed and not doing anything. And I think that may well have profound effects on grey matter thickness and connectivity. I'm not so sure that a nicely judged antipsychotic dose, just enough to get them well, but not too sedated, would be having such dramatic effects. So the Enigma consortium have also addressed this issue directly in terms of their thousands of scans of people with schizophrenia. So you find this overall effect, but the direct correlation between antipsychotic dose is small. So if you look at people with unmedicated schizophrenia in the Enigma consortium study of schizophrenia, you do find an effect. So there is something that is definitely there in terms of here reduced grey matter volume in unmedicated patients. But the effects seem to be larger in those on second-generation antipsychotic drugs and larger still in those patients on first-generation drugs. But then, of course, the problem is that people don't only get antipsychotic drugs, and especially large doses of antipsychotic drugs, if they've got relatively severe schizophrenia. So these observational studies, there is always the potential for something called confounding by indication. So the most severely ill patients will get the most antipsychotic drugs at the highest doses for longer. And so even if you show an apparent dose-response effect in people with schizophrenia, it could be because they've just got a more severe illness. And we are probably never going to do, well, people have tried to do randomized controlled trials of people getting antipsychotic drugs or not, and brain imaging as part of those trials, but they never work. There's so many people drop out of those trials and studies that you can't generate reliable results that would really tell you for sure whether being randomized to an antipsychotic drug would actually be associated with an apparent cause of loss of grey matter volume. Okay, what about early detection? So the first study that used the idea that you could use reduced grey matter volumes to detect schizophrenia early was this one by Nikos Koutsouleris in Munich and his colleagues. And they, like all these studies, really, with the exception of ours, used structural MRI and voxel-based morphometry to try to detect schizophrenia early. They generally have also used a kind of machine learning approach to optimize the detection of any changes. So you can see here, across the bottom, in red, changes over time as people at clinical high risk develop schizophrenia as diagnosed using standard techniques. And you can see in this not very clear slide, sorry, that in the 15 who made the transition to schizophrenia, this pattern of grey matter changes over time as detected by machine learning was associated with something like 87, 88, 89% overall accuracy, specificity and sensitivity in terms of predicting, using brain imaging as a predictive diagnostic test. Quite good, actually. Small numbers, but these kind of sensitivities or specificities are about as high as many of the diagnostic tests used in medicine. This paper was published in the Archives of General Psychiatry in 2009 in clinical high-risk people, and our contribution to this literature, done by my PhD student Eleni Zaragiani, published in these papers, looked at changes over time over the first 2 scans in the Edinburgh High Risk study in those at high familial risk. Again, used structural MRI data with machine learning. We also added in, for a secondary analysis, the 2 clinical variables that were most strongly predictive of schizophrenia, which was a memory test and a self-rated measure of schizotypal personality. I think the translators are still talking. I might give them time to catch up. Or is that the next door speaker? That is the next door speaker, so I better carry on. So, yeah, what we did when we looked just at the structural MRI, ability to predict schizophrenia, this is between 2 years and up to a few months before they developed schizophrenia, we found 13 out of 20 brains true positives, no false positives, and an overall sensitivity of around about 76%, specificity of 100%, and accuracy of 88%. So again, sounds quite good. But in this context of high clinical risk, of high familial risk of schizophrenia, any error, any false positives and negatives are quite concerning. So, you know, in these people with a strong family history who know that this condition runs in the family, we had 4 false negatives out of 20 people who would develop the illness. So in other words, we would have told them, you're okay. Based on 2 structural MRI scans, you're not going to get schizophrenia, and they promptly went and did. So that's a rather uncomfortable place to be. But when you combine the structural MRI with this memory test and schizotypal features test, the data goes slightly the other way. You get 100% sensitivity this time, an overall accuracy of 94%. We get 2 false positives out of the 17 high-risk subjects who went on to get schizophrenia. So we would have said to 2 of these young folks, based on your family history and your MRI scan, you're going to get schizophrenia in the next 2 years, and they wouldn't have done. And that might have caused all sorts of problems. They might not have finished college. They may have contemplated suicide. We're seeing schizophrenia as a fate worse than death, although it usually isn't. So this potential that undoubtedly exists for using structural brain imaging to detect schizophrenia early brings a whole host of novel ethical considerations and concerns. So that is a very active area of research across Europe and the world generally, trying to use structural MRI to detect schizophrenia early. I'm going to close by talking about positron transmission tomography studies, just 1 or 2 examples, because this is a similar consistent literature to the MRI studies in schizophrenia. This is a systematic review and meta-analysis done by Ollie Howes and colleagues, published in Archives 2012, looking at fluorodopa as a measure of dopamine turnover in the striatum in the brains of people with schizophrenia. So there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, about 15 individual studies published between 1994 and 2010. Generally in, where's the number of patients? Can't see it on this slide actually, but generally in around about 15 to 20 patients versus healthy controls. And what these studies did was they inject radioactively labeled fluorodopa into the veins, which is then taken up selectively, particularly in dopaminergic nerve cells in the striatum. Dopa, as you all know, is made into dopamine in the presynaptic terminals. So fluorodopa is made into fluorodopamine and released across the synaptic cleft. And you can measure this release using positron emission tomography, which is basically a fancy gamma camera that can detect radioactivity focused with that level of accuracy. So we're particularly measuring dopaminergic synthesis and release in the striatum and in the substantia nigra as part of the nigrostriatal dopaminergic system here. And what you find across the piece in all these studies is an increased turnover of fluorodopa in people with schizophrenia. Some of these are in unmedicated patients. There are other studies showing that you can exacerbate this effect by giving patients amphetamine, and that exacerbates their psychotic symptoms. So we have very clear evidence here that there is a dopaminergic overdrive, if you like, in people with schizophrenia, and that's pretty much a fact. We don't know whether that's the primary deficit All of this may be secondary to glutamatergic changes, but those have not been as reliably measured, at least as yet, in people with schizophrenia. And Ollie House has gone further than that, so rather like the clinical and familial high-risk literature that I've shown you with structural MRI, they have looked at people with the at-risk mental state or the clinical high-risk state with this PET camera technique, and they found that this measure of dopamine turnover in the striatum was increased in people at clinical high risk, but not as high as in those with schizophrenia. And that was in a paper in Archives in 2009. And over a two-year period, they did repeated scans in some patients, and they found that the ones who were most likely to develop schizophrenia showed greater increases in dopamine turnover. And the extent of these increases in dopamine turnover were related to increasing severity of psychotic symptoms. So this is good evidence that as people develop schizophrenia, their dopamine overdrive is increasing, rather like their grey matter seems to be shrinking. Okay, so we've made it. Hopefully, I've been able to communicate this reasonably effectively to you. What I've tried to show is that schizophrenia is clearly associated in thousands of patients. These are pretty much established facts that schizophrenia is clearly associated with disruptions in brain structure and chemistry. That for the structural MRI literature, you find similar effects in the post-mortem literature, providing some validity of these findings, concurrent validity across different techniques. That some of these effects on structural MRI and PET are related to features of the illness like cognitive impairment and symptom severity. That they are multifactorial, of course they are. Things in the brain are related to multiple genetic and environmental events, but they are related in a detectable way to certain key genetic and environmental risk factors, and that these are opening the possibility, at least, to using structural and functional and chemical brain imaging techniques to detect schizophrenia early, with a view to enhancing the outcome of the illness with earlier and better treatment. So, thank you for your attention.